Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site. Hi, I'm David Kaufman. I'm here with Eileen Ruhoy.
Hello.
And welcome back to Unraveled. We are going to try to have a long episode, actually we'll break it into 2 episodes, on the defining symptom or pathology, I'm not sure, symptom of post-exertional malaise, PEM, something that all of you or most of you know and hate. I'll start out by saying, just as the term chronic fatigue syndrome is really terrible, PEM is just as bad as far as I'm concerned. I mean, what the hell does post-exertional malaise mean? What does malaise mean in that context, you know? You might as well say post-exertional fatigue, but neither term explains what's going on and makes the distinction between I walked up the hill and I'm tired versus I walked up the hill and I'm in bed for the next 3 days. And it's unfortunate because I think that's what's, or one of the things that has kept CFS, MECFS in the dark hinterlands that's ignored by mainstream medicine.
Yeah, I think post-exertional malaise is one of those symptoms that is really hard to nail down. It's really hard to articulate. It's really hard to understand. And it's described by many ways. In fact, I know we both worked with that group at Boston University that recently actually had a paper accepted for publication on the work that they had done that we had helped with trying to really understand what the post-exertional malaise is about with all those questions, basically the questionnaire that they designed that will be useful for a lot of primary care physicians in their office.
Have you ever tried to explain to a primary care or neurology non-acquainted with MECFS physician what PEM is?
I've tried, yeah, of course. It's impossible.
You know, and most of them don't believe the patients because how could that be? What do you mean you went shopping or you had an appointment with your doctor and the next 2 days you were in bed? What are you talking about? You must be nuts.
Right. No, exactly. Or I've heard actually doctors say, yeah, I'm tired too. Yeah. You know, I get tired too. Oh, that exhausts me as well. Yeah, if I didn't sleep well the night before, then, you know, going to the grocery store is like a big ordeal for me. Like I've actually heard other doctors say this, you know, when I tell them about a patient. Yeah. So it's very dismissive.
It's a terrible term.
And I think it's really because it's so hard to explain. And you know, when I talk to patients, I really try to get to the bottom of what they're feeling. And I end up, you know, the more I question, the more their vocabulary sort of goes down to a more of like an elementary school level. Right. And then I start hearing words like, I just feel gross. Yeah. You know, I mean, have you heard patients say that?
Yeah, sure.
Yeah, I feel gross. I feel yucky, you know, and that's what the malaise is that they're feeling. I feel sick. Yeah. So, and so I think it's beyond, I think fatigue is actually the wrong word.
No, it's terrible. And it's been now institutionalized or memorialized or whatever the word is because the Institute of Medicine, when they came out with their report in 2015, they made PEM the cardinal symptom. You cannot diagnose MECFS without PEM. Brings you back to the question, what the blankety blank is PEM?
So what is it? Right. So I think it's a couple of things. I think it's, yes, even with minimal exertion, so minimal activity, they no longer have any energy to do anything else. But it's also about the recovery of minimal exertion, right? So there might be prolonged recovery. In fact, you may not feel the fatigue or the malaise directly after that task or activity, but find that the next day you crash.
And that's what sets it apart and makes it even more unacceptable to the rest of the world. What do you mean you have to be in bed the next day? You walked for half an hour and the next day you must be nuts.
Right, exactly. Yeah. And what's interesting is that when they start the activity, they feel perfectly fine, right? So they don't feel like they have, not fine because obviously they still are MECFS patients, but I meant they feel like they have enough energy to complete the task at hand, whatever that may be. Right. So they don't really sense the idea that they're going to have the PEM following this particular task or activity. So, and again, and understanding this requires, as we always talk about, like a real conversation with patients. Like, so, and sometimes I think that PEM really is the patient experience, just sort of like I think of brain fog. And while there's a lot of obviously very overlapping similarities to what the patients feel, there's also some distinctions and differences. And so to sort of understand what PEM means to a particular patient, I think can be very insightful and very enlightening, actually, and give me a clue as to how to help that particular patient.
I think absolutely begins with that conversation, but even before that, as something we've addressed or discussed many times, it begins with a willingness and an openness on the physician's part to simply believe what the patient is saying, even if it sounds nuts to you, even if it doesn't make medical sense or scientific sense. Patients are not going to come into your office and lie about something like, quote, post-exertional malaise.
I completely agree. And it's important to point out that this is a distinct entity from just chronic fatigue, right? In fact, we talk about fatiguing illnesses now with long COVID, which is the most relevant and more common. I wouldn't say more common, but more talked about one these days is a fatiguing illness for sure. And there's just sort of this baseline level of like, I just feel tired all the time.
They have the same PEM.
And they have the same PEM, but it's a distinction, right? They say that I'm fatigued, but then I do something, and then there's this. I think that's why I like the malaise word as opposed to fatigue, because the malaise seems to sort of encompass this yuckiness feeling that they often talk about. And so I try to get to the bottom of that, of what that could really be, because if we're not talking about pure energy, then it sort of takes on a different form when I try to I come up with thoughts as to what could be causing this and how, and more importantly sometimes, is how I can treat it and make it better.
Yeah. So I think that's important. And I think that the difference between fatigue and malaise here is that when the patient is experiencing PEM, the message I get, what I see and hear, mostly hear, is it's a completely systemic phenomena. It involves everything from top of my head to my toes, as opposed to, doc, I'm just tired.
Right.
There's a real difference. And I think that in that difference, in that systemic nature, that's where the clues are as to what the hell is causing this, because that's what the real question is.
Right. And also it's what the activities that can provoke it, right? So it's not just, large muscle group movements. So it's not walking. I mean, obviously it is, but it's not always walking or going to the grocery store or cooking a meal. I've had patients say that when they are typing at the computer, just the use of their fingers, playing the piano,
and that's why it's so important
eating,
to emphasize the systemic nature of it.
Talking.
And the first time you hear it, full disclosure, the first time I heard some of these things, it was kind of like, you're telling me an email made you tired? Right. Made you, PEM? I have so many patients where they basically plan their appointment with me, their 60 or 90-minute appointment, and they say, this is all I'm going to do, and I've spent 2 days before the appointment resting, and I will be out of commission tomorrow from just sitting in a chair and talking, not even in a chair, lying down on the couch, talking to you.
Yeah, and you can even see it happen with some patients. Towards the end of the appointment, all of a sudden they're not answering my questions as robustly or as completely. They don't remember, they're having word recall issues, whereas at the beginning of the appointment, I'm thinking, wow, you really are right on task.
I had a patient yesterday just like that.
Yeah.
So about 25, 30 minutes into the call, and he was very vocal and verbal and stuff. He suddenly was like this. And I said, hey, are you there? Are you okay? And he said, yeah, I'm all right. And it just started to fade away.
It happens all the time, actually. I've had a couple of patients who sitting upright, talking to me, answering all my questions, via telemedicine, but then they had to actually sit on the floor and then lie on the floor. And so you can see it actually happen in front of your eyes. And I usually try to then cut the appointment short, because it's not going to be all that effective or efficient once they are getting in that stage of the post-exertional malaise state. So it is a real thing. And so again, and there's also talking, chewing. And when I think about all of the different things that can contribute to this particular symptom complaint, I can't help but think about, of course, what we see with the CCI patients, right? So severe post-exertional malaise causes, I think, basically our bedbound patients. I mean, to me, that's severe. So any minimal movement will cause, and we've had many of those, right? So where they say that even just trying to eat a meal from bed that's being served to them by their caregiver can actually cause them to crash.
Just thinking.
Right.
Cognitive cognitive
Cognitive,
function,
absolutely.
listening to an audible book.
Yes, exactly. And so I recently had a patient tell me about how she has to go into an HBOT machine in order to read one of her, she's in college, she had to read one of her textbooks because the added oxygenation to her tissues, and where she's, of course, referring to her brain, seems to allow her to concentrate and focus better and lessens the level of cognitive fatigue she has after reading a textbook.
Right.
So it just makes me think about how we've always said that, bedbound patients have CCI until proven otherwise. And so I think about the brainstem and all the different functions that the brainstem is involved in because of all their different nuclei that are contained within the brainstem components. And I can't help but think that a really good thought is that there is some baseline level of brainstem hypoxia going on that is contributing to this systemic overall fatigue and malaise. Because they're just having compression of their brainstem,
Right.
compression of the vessels that feed the brainstem, and I think that somehow improving, and once there's no oxygen, and every time I say this, it's not like it's an ischemic kind of milieu where like people are at risk of strokes. I think it's more this sort of basal hypoxic state of which technically many people live in for a long period of time. And I mean, even if you think about like emphysema, some of those, lung disorders, the what do they call in medical school? The blue bloaters and the
right.
puffy pink puffers.
Oh, I haven't heard those terms for a mere 4 or 5 decades.
These things that they teach you in med school just so you remember stuff.
Right.
I mean, those patients have like a low level, state of hypoxia,
Right.
or sometimes elevated carbon dioxide for a long period of time.
But I think there's a key difference. I'm really glad you brought that up. Okay, because why don't
Pink puffers,
they
I'm
have?
glad you remembered that.
But why don't they have post-exertional malaise? Why?
Because their brain stems aren't affected. Because
But they have less oxygen.
They have less
why
oxygen
can a pink puffer
circulating.
or blue bloater sit in his or her chair, usually a his, because it was mostly men smoking cigarettes,
That's true.
and watch a football game and even cheer and do the football thing and not experience these symptoms? And I think a key difference here is it's not just perhaps a lower oxygen level, PO2, arterial oxygen level. It's a decrease in perfusion. There is less blood flowing to the brain with less oxygen.
Right. I often say this. I mean, so I talk about how we can improve blood flow. We can increase the number of oxygen molecules that are in the blood. We can increase the carrying capacity of the hemoglobin to carry the oxygen molecules. We can even increase blood flow, right? We have all these blood thinners and vasodilators and ways of improving blood flow. So we can deliver more blood to an area of need by several means, and maybe it's not 100% efficient or 100% optimal, but we can improve upon it for sure. But to perfuse the oxygen is a whole other ballgame, right? And as you know, these patients have been chronically inflamed for decades, and so and I often talk about, even when I refer to plasmapheresis, one of the reasons why you can't just do one is because things love to marginalize along the lumen walls, and if there's a lot of inflammation for a long period of time, there's a lot of mediators and a lot of things that happen to the cells because of the inflammation, and they love to marginalize and stick against walls. So in the end, you have this, what I refer to as an inflammatory barrier of the lumen, which, as you know, is the vessel, is the center of the vessel that is where the blood is circulating. It sticks on the wall. So there's this barrier to perfusion. And so what the oxygen molecule needs is a force. Remember the physics? Talk about going way back.
Now you got me back in the pre-med.
Right. It's like velocity times force or something, but you need force for optimal perfusion. Right. And that's where I love hyperbaric oxygen, frankly, which is why I brought up that patient who said that she can't read a science textbook unless she's in an HBOT machine, because that's one way of improving the force. Of course, as you know, I'm a big fan of the Vasper. I think I talked about it during our live, which is another way of improving perfusion. So again, we can increase the number of oxygen molecules on the hemoglobin. We can increase blood flow, but we have to work on perfusion, because otherwise, what's the point, right? So if the brain parenchyma is not getting the oxygen, then mitochondria can't work, for example, which I think is a really important organelle that we have to focus on when we're thinking about PEM. But the electron transfer chain and oxidative phosphorylation needs oxygen. If it's not getting enough oxygen, it's not going to do its job, and it's not going to make as much ATP as the very metabolically active brain and brainstem need. And so it's a whole series of events that I think that we need to focus in on. And there are some ways of treatment that we can, I think we've had some success in lessening the severity of the PEM in some patients with what we're talking about now with different approaches, but obviously we haven't cured it. So
well, I think what you're saying, and we discuss all the time, is that we have this name PEM, but the cause is multifactorial.
Mm-hmm.
All right, and perfusion is certainly one, and I think it's not a coincidence that I don't think I've ever had or met a patient, either MECFS or long COVID, that did not also have POTS of some kind.
Right.
All right. And I use the term very loosely, POTS. Okay. It's another term that's problematic in some ways. And what I really should be saying is that it's not a coincidence that every one of those patients has some element of hypoperfusion. And that's a relatively low-hanging fruit. We can do something about that. And that helps. That's why a patient will get on a call with me and say, well, I'm a little better, I could do a little more. And then when I look at their lean test, the numbers are a little better. They're not normal, okay? And they don't necessarily meet criteria for POTS, so they would usually be ignored by other physicians, but they're better than they were. So instead of going from a heart rate of 60 to 130, they go from a heart rate of 60 to 80, which is still not normal,
Mm-hmm.
but that implies a better perfusion. And I wonder if you've ever seen this. One of the things I've started to see or recognize, become aware of, is that as the initial patients often present with POTS and orthostatic intolerance, implying their blood pressure drops, right?
Right.
Their heart rate's 140, going too fast, their blood pressure drops. As that gets improved with medications, they seem to convert almost to a hyperadrenergic picture, where the heart rate doesn't go up as much, but the blood pressure now is going up to 150 over 90.
I have seen that.
It's so interesting.
It is.
Really
Yeah, they
interesting.
develop it, and it becomes labile though. It's, so it goes
and
up and
it's
down.
almost like the brain is saying, all right, well, you sort of fixed me, so now I'm a little more aware of what's going on, but this is still bullshit, and I need more blood pressure and perfusion, so I'm pouring out my sympathetic signals.
Yes,
Those
100%.
adrenals got to kick in because I need perfusion.
Right, and sometimes I think it's a reassuring sign, and while it can cause its own set of symptoms, of course, I do think it's the body's way of trying of pulling in its homeostatic mechanisms.
That's
Yeah,
what I'm
no, for
saying.
sure.
Exactly.
And I explain that to patients, and I think that we're sort of onto something. And I think if we just sort of manage the body's sort of overcorrection is how I see it. If we can manage it and sort of rein it back a little bit, we can try to find some, level of homeostasis that serves to sort of fix the symptom that we were trying to fix to begin with, but
Right.
prevent the overcompensation by the body. Because, a body that's been so chronically sick really doesn't really know what to do.
Right.
And it still has those innate homeostatic mechanisms, but it overshoots fairly often. I see this all the time. And you bring up a good point. I mean, so, we talked about hypoxic state and perfusion and mitochondria. Briefly, not. We should talk about it. We should talk about it more. Yeah.
Soon.
But
Soon.
right, but you brought up POTS. I mean, so I think that PEM is multifactorial,
Yeah.
and even our patients that have chronic pain. I mean, so pain is very energy draining,
Right.
and so any kind of movement or any kind of exertion will just recruit some of those pain pathways. Right? These are all pain pathways that are sort of overexpressed and overregulated now.
So let's expand on that, okay?
Yeah.
And I think this is a key part of this discussion. The easy answer to this whole episode, or 2 episodes, is for us to only talk about mitochondria. We'll get to that, okay?
Yeah. I'm not so sure it's the most important.
I'm not saying it's the most
I think it ultimately becomes about the mitochondria, but what is sort of weighing on the mitochondria, I think, are even more important to talk about.
Right. I think they're
Do you like
key,
my hand movements?
partly because we have so few tools to manipulate and help them. Okay.
Right.
But I
that
want
is
to
true.
emphasize over and over this multifactorial nature. So we could go on for another hour about POTS, but we'll leave that. So I'm glad you brought up pain. So what does pain do? Well, aside from feeling terrible, it is fatiguing. It will kick off mast cell degranulation, which kicks off pain, which kicks off mast cell degranulation, which kicks off POTS, because all of those vasoactive cytokines, the 1,000 cytokines released by the mast cell, cause hemodynamic chaos, okay? One of the models to understand this to me is the whole sick syndrome, okay, a little bit like Bob Navio's cell danger response issue, there are chemicals that make people feel sick. You know, I think we briefly touched on this before, how interferon, which is produced in response to a viral infection, will make a patient feel tired, exhausted, depressed, and just want to sit there like that. Okay? So that's what the flu does. That's what COVID does. That's what long COVID does. That's what treating with interferon does. That's what chronic pain does. It's so many different so many different forces that intersect on post-exertional malaise.
I completely agree. And if you think about our septag patients, almost every diagnosis contributes to the post-exertional malaise.
Which is the reason the septag concept remains so important.
Right.
There was somebody on, I don't know if you saw this, on Masterminds, the listserv. He said he's writing a paper and he knows everybody keeps talking about the septag, but he can't find it in any of the textbooks. Does anybody have any papers on it?
Just credit Andy Maxwell.
That was the answer from Larry, of course. And it's not in the books. This is something we use, but it is such a powerful concept precisely because it demonstrates the multifactorial nature, and it guides the workup, and it lets us go after the low-hanging fruit. So we can fix, or mostly fix, POTS. We can deal with MECFS. We can, not so effectively, but somewhat deal with pain. But then when you've dealt with all that, that's why that mitochondria starts rising to the top.
But all those things weigh upon the mitochondria.
Yes,
so,
but they also probably have their own fundamental pathology.
Oh, for sure. Yeah, I mean, those organelles they have so much job to do. Right. And when they fail, the systems fail, and that's the problem. And they're everywhere, but so are mast cells, right? And so is connective tissue.
Right.
I do think that if we can somehow, though, improve oxygenation, that goes a long way in helping the mitochondria. It also just goes a long way in helping cellular signaling and tissue function, and specifically the brainstem. Right. So all those functions these are all brainstem oriented or spinal cord oriented. So, and I think it just brings us back to cranial cervical instability, which again is another part of the septag.
Well, that's
right.
Unfortunately, how patients get to cranial cervical instability. In other words, the argument I would make is the patients don't start out with cranial medullary syndrome. They don't start out with CCI. They get there, and they get there because of this chronic inflammation and all of this destructive processes, with or without EDS. If they have EDS, they may get there faster, sooner, which is not a good thing. And I think we talked about this in a prior episode, once they get there, once we have brainstem compression, all the other usual problems are made worse, and they don't get treated the same way. And that's what's so challenging. In other words, my argument here, and I think yours is, it's one thing to give a beta blocker or guanfacine or fludrocortisone to manage POTS, again, using that term loosely. But once you have a brainstem compression syndrome, those meds are not going to do much, and that's why those patients are stuck in bed.
I completely agree with that.
The mechanical cause for the problem.
Right, and we always, I always say you have to fix the anatomy, and then you fix the metabolism and/or the pathophysiology. And what's interesting to me, and I don't know if you've seen this with your patients, is that every time there's a surgical intervention, there seems to be complete remission of the PEM for a period of time, and then it recurs. Right. So what's that about?
I have theories. I'm not sure. I
what
can
are
tell
your
you
theories?
It's unbelievably frustrating for the patient and for me.
Oh gosh,
it's just terrible. One easy theory is patients overdo it once they feel better.
Right.
That's easy, and I think that is real. I think it happens all the time. I think it's part of the homeostatic mechanisms you describe. So fixing the CCI doesn't mean all the other pathology we've been talking about is fixed instantly. Unfortunately, it often unmasks an occult tethered cord, so then the mechanical problem is recurring. Mm-hmm. That's actually one of the most common causes in my patient group where that happens. I don't have a great explanation. I have some explanations.
Yeah. What I've been doing is basically I go searching for, because I see these anatomical misalignment diagnoses, is how I see them, first of all. I see them as one and the same, I go looking for others, right? So you identify the cranial cervical instability and the subsequent cervical medullary syndrome, and you can identify, of course, the compression disorders of the IJV, whether it's from the C1 tubercle or the styloid. You can find a tethered cord. Then I go looking for other compression problems, right? So whether it's thoracic outlet syndrome, which I regularly find, or one of these abdominal pelvic kinds of interesting diagnoses like May Turner and Nutcracker and so on. And I find them, which is interesting. And they're not always, and the funny thing is that very often I don't even get GI, like classic GI symptoms of, for example, MALS, median arcuate ligament syndrome. There is no postprandial pain necessarily. I mean, as we know, most of these patients have some level of dysmotility, but that's related to the autonomic nervous system dysfunction and the small fiber neuropathy, and usually SIBO and leaky gut and so on. But they don't have more classic symptoms of some of these compression syndromes yet. You do a mesenteric angiogram and you find compression.
I think one of the messages here from your little talk just now, this is, I think, important, okay?
From my soapbox.
Well, yeah, and I think it's important for our listeners to understand.
What I'm saying is, you didn't let me finish my thought.
I'm sorry.
What I'm saying is that this sounds crazy to even me. Like, I'm sure, like, believe me, what other doctors like going looking for compression syndromes? Like, it's so ridiculous to me, but I can't help but think there. They're there. These are EDS patients or connective tissue patients, however we want to refer to them. So their vessels alone have a higher level of compressibility, even by the slightest of touch. So while compression, as we were trained to think about it, is like compression, stenosis of that vessel. In these patients, it's not necessarily a true stenosis. It's just like, the slightest touch, even like a stomach distension, even a normal stomach distension from a normal meal can just cause a compressible vessel to collapse upon itself. And so, these patients are just different is what I've learned over the years. And so I just do it differently. And I'm sure that I look like a crazy neurologist to a lot of my colleagues, but I just order, and, these are usually ultrasounds. So they're, it doesn't really need approval. So it's easy to get. And then when I find concern for compression, I refer them to a vascular surgeon or to someone who could potentially consider maybe fixing this. And I will say, in the few patients that I was able to get someone to help fix this compression problem that we found, there was improvement. So, I think that we just find so many more questions than we have answers for. And unless we go looking for the answers, like we're never going to move the needle. And, another one of our soapboxes, of course, is this whole evidence-based idea, which we are both big supporters of, but I can't wait around. These patients are suffering, right? So if I have to order an ultrasound, just try to find something, I'm going to order an ultrasound.
Well, and there is no evidence-based because nobody's looked at this until now.
Right.
Okay, so what I was going to say...
Yeah, sorry. I just wanted you to know that I know this sounds crazy. I'm not suggesting that this should be standard of care yet.
Obviously, it's not crazy. And the message here is we are still in an enormous learning curve, okay? I mean, 10 years ago, I never heard of CCI, okay? Recently, I'm like literally up at night learning and thinking about these compression syndromes, okay? The more we do, the more we realize we don't know other things. And it's very frustrating for patients. What do you mean I need another scan? I might have a C1 pressing on my jugular vein. What are you talking about? I just went through this horrible surgery. Now you're telling me I have a new problem? What do you mean that I have pelvic vein compression syndrome and now I have to get a stent?
Oh, the pelvic veins
and we're
now.
just learning it.
That's because of the listserv.
It is the listserv. I'm telling you. That's
I was like, the pelvic veins. I haven't been looking at the pelvic veins.
I love it. I love it. It's like having medical school every day, but without the
I know.
anxiety.
I know.
But it's a really important point, and I'm not telling patients don't be upset, but I think they need to appreciate that we are all learning this on the fly, And yes, that's not ideal, but at least we're trying. There is no evidence base because nobody's ever looked at this stuff.
Exactly.
Right? I mean, you look at poor Paulo Bolognese, everything he's doing is considered outlandish, outlier, and rogue and cowboy by the neurosurgical community, the traditional mainstream. Does that mean that he is those things, or does that simply mean he's willing to do the work that needs to be done and collect the data and publish it, even if they won't read it? And, we just can't go by evidence-based only. We have to go by what we try to figure out.
Right, and publish what we find, right? That's what I think. I mean, I say this all the time. It's easy, of course, I never have that.
When am I going to find time to publish the last 10 patients, each one of which
Well, that's
has
why
an important
that's
finding.
why I think a collaboration is important, because I think we all have a little bit of time that we can give towards a paper, and somehow if we collaborate, we can
Yeah.
get a lot of this published. I mean, I literally have about 5 papers that are like in the middle of at different stages on my
Well,
laptop.
you're way ahead of me. I just
start, like, I have an
think of it,
idea.
but I can't.
I mean, 10 p.m. at night, like, I'm like, oh, I have to write this up, and I'll just start writing, and I get a bunch of paragraphs done, and then I have to go to bed, and then I don't go back to it for weeks. And so, we just need to get stuff published. And of course, the question is, who's going to publish it, right? Then you have to worry about actually being accepted by the journals, and especially if you're talking about something that's so outside of what's been considered standard of care for so many years.
Let's just call it out. The big dark secret of this wonderful concept of peer review is peer review means those are peers who are not necessarily peers and don't know what we're talking about. Okay? And so it makes it really hard, and that's the reason medicine remains this profoundly conservative profession, taking 10 to 20 years for changes to occur. It's the reason when you submit a grant to the NIH, which I don't do, but when you do try, if you're not studying in your grant the same thing that they're all studying, they just tell you to go take a walk. They're not going to give you money. They don't want to fund out of the box things.
Absolutely.
Look at Recover and long COVID, okay? It's now, I think it's just over a year that they have $1 billion. And what have they done? They've collected data on how many people have long COVID. Give me a blankety break, It's crazy. Sorry.
No, don't be sorry. It's a really good rant, and it's so true. And it's why MECFS patients have long been not well understood and not accepted. And it really has, it's done a lot of damage. It's done a lot of damage to these patients. It's done a lot of damage to their families. It's done a lot of damage to research efforts.
Yeah, damage is an understatement.
Oh, yeah.
It's terrible.
Right. So I think that, which is why I really like working with doctors like you.
And me too with you.
Because we're making a difference. So yes, so this is what I've been doing, which again, I have to just reiterate. I know it sounds crazy. But
it's not crazy.
There are days that I'm like, I'm crazy.
I mean, but look at the business. Look at our colleagues. Okay, I had a patient yesterday. I'm going over her Doppler study, vascular Doppler study, and the report. So she's like a pre-med student. Okay, so she knew, because I discussed it with her, to go for this study. She had a pelvic pain syndrome. Mm-hmm. So I sent her for a Doppler flow study to measure flow. And I told her, if you can get them to do it lying down and standing, it would be very helpful.
Ooh.
Okay. So she
I haven't done that.
She did. Okay. I got the report. Two comments. This is the report, literally, okay?
Yeah.
SMA, less than 70% stenosis. Celiac, less than 70% stenosis. So I have 2 questions. Where's the supine and the upright? No comment. It's not even there. And what the hell does less than 70% stenosis mean? You mean if I have 69% stenosis, I don't need to worry? They told her nothing. They said, no problem.
That's how they read carotids, right? Because they say that if it's less than...
But that's back to this evidence-based garbage.
Right. No, I no, that's where I was going with that. Exactly. The carotids, they say that you don't have to correct the stenosis if it's less than, I forget now the percentage. So they report it like that. But I've never seen it reported like that for any of the...
But let's underline it. That where is the data that says
there is
you
no
need
data?
To wait until 71%?
There is not
before
for those.
Your risk for a stroke.
There's data on carotid. No, there is data on the carotids because that's part of a stroke workup. So there's lots of literature on when to go in and remove like plaques of a carotid because there's a greater risk of stroke.
So when it's 69%, bye-bye. Have a good time. Come back when you're 71%.
Right, and that's the other thing. I don't remember the exact percentage now, but there is literature to support a certain percentage of when you have to go in and remove the plaque versus not because of risk. But I will tell you that a patient, they're told that they have like 60% stenosis of their carotids. Like nobody just goes to sleep at night feeling okay.
Well, and it's just wrong. It's like
it's just
one
wrong.
of the things I love about Peter Attia's podcast. Right? I mean, you can say what you want about him. He's a little whatever, but he does these great podcasts, and he makes this such a strong point about in hyperlipidemia and cardiovascular disease. We have all been taught pretty much wait till the patient has chest pain syndrome or a heart attack before you intervene. If the low density lipoprotein is 100, big deal. Wait till they get sick. That's basically the concept.
Well, that's all of medicine, though.
Right.
Wait until you're sick.
Yeah. Rather than intervene now, either 30 years old or 40 years old or 25 if their LDL is that high, so that when they are 60, they're not going to drop dead.
Right.
It's
Well, I mean, medicine has never been preventative.
I know.
Never. Right. And so I think, and and just sort of going back to our complex patients, like when I get their story, I can't help but think, like, what could we have done when you had this very severe case of mononucleosis when you were 19 years old?
Exactly.
Like, what could we have done then? Only because I want to prevent the next generation of MECFS patients, right?
Which is really where I think the focus needs to be. Prevent the onset of CCI.
Completely agree.
Prevent the stroke.
I've had an influx of patients like in their early 20s, and I'm excited about that because I feel like I could potentially get a lot more done for them to prevent progression into what I see in my 50-year-olds, for example.
No, I totally agree.
So, but I do think about how we could be more preventative even for our complex patient population. And we're not going to, obviously we would love to predict who's at risk of developing MECFS before they're even sick, before they even have a viral infection, for example. And I think there's a genetic variant that makes them a little bit more predisposed. And I wish we knew what that variant was, and I would try to lobby for it to be on newborn screening. Talk about becoming unpopular.
Right.
But until that time, it would be great if we can figure out how to stratify what people are really at risk and what people aren't. We've sort of come up with this, which I don't even know where it was arrived at, but that if you have hypermobility as a young person, that somehow you have greater risk factors. I'm not so sure that's true. I mean, you've heard me say that. I don't think being born flexible is a disease. I think people are just born flexible. But I think if there are, again, going back to a very strong history taking, if they're flexible but also have certain things during childhood. I mean, as you know, I regularly ask about childhood, even pregnancy and delivery, and I'll often get, they were hypotonic when they were born. They didn't walk until they were 18 months of age. They had a hernia at age 7. I mean, who has hernias at age 7? There was someone had a prolapse at age 19. I mean, what? Yeah. So those are clues that it's not just flexibility. There really is a connective tissue problem.
Yeah.
I think that's important to point out because it's not just about your joints. And we say this all the time, I know, but I think we're missing the forest for the trees or the trees for the forest. How does that saying goes? Jillian's really good at that stuff. I'm always getting it wrong.
But I think it's an important point that it's puzzling and therefore revealing that such a large percentage of our patients, when you look for it, have connective tissue disease. And it's not even before they're hit CCI and even when they're still young and haven't had decades of chronic inflammation. Why is it? All right? It's not coincidence. It's really important. And
it's not.
And yes, I can't do anything about that except discover it and treat more aggressively because now I'm fighting something that can't be fixed, which is the connective tissue thing, or at least we're not sure how to fix it.
Right.
But I think it's a really important point. And I think it brings us right back to the cascade of events post-surgical fusion surgery of why you're suddenly looking and finding compression syndromes and, jugular problems and celiac problems. Those problems are there as part of this bigger picture, but they were kind of overshadowed. They were background noise because when you have somebody who can't move their neck or get out of bed, that's the most important thing.
Right. No, for sure. I think that when we correct it surgically, that is like, let's take the CCI. Obviously, the brainstem needs oxygen, and so all of a sudden there's an improved blood flow. And I think that there's a remission and there's a great improvement. And for many patients, it's sustained for a very long period of time. Some for a short period of time, then they relapse. And so I think, okay, well now another hypoxic organ is rearing its ugly head, and I have to go searching as to the reason why.
Maybe because they're more active.
Right, and now they're more active.
More active
right.
in a negative sense, but now they're twisting and turning, and that compression's getting aggravated simply by being alive and able to get out of bed and move.
That's exactly right. So when you're when you're lying still in bed, there isn't much activity to sort of provoke and challenge other vessels and organs. You're right. And so now that they've had their craniocervical instability corrected, they have a little bit more mobility. I mean, they all do. And I mean, the most amazing thing that we see with these patients is that they are no longer completely bedbound. Right. They're able to be upright. And that's really exciting, and especially for the patient who've been bedbound for so
Oh, yeah,
long.
yeah.
I mean, it could bring tears to my eyes with some of our patients who've just can't believe how their life is
No,
different.
it does bring tears.
Right, but you're right. So now they're more mobile, they're more active, they're doing more things, but they still have a connective tissue problem, right? And so then eventually something else sort of crops up, and I regularly see this. This is not an uncommon presentation where we fix one thing, and then at some point, again, it could be 6 months, it could be 5 years, but at some point something else sort of recurs, and then I have to go searching, okay, what went wrong now? But I have like a handful of patients that it's like they have almost complete remission after every surgical intervention for a few months, and then symptoms and they never go back to the baseline that they were, which is like completely bedbound. I mean, they always overall have improved, but symptoms that are similar to the PEM, which is what we started talking about.
I know. Remember PEM? Yeah. This is all relevant.
They'll say things like, I started to feel the PEM again. And that scares them, of course, right? It's like, they remind me of when I used to just be a typical neurologist. I miss those days. And I did a lot of bread and butter neurology. Like my migraine patients or my seizure patients, like they lived in fear of their next seizure, of their next migraine. And oftentimes there's an aura or a prodrome, as we call it, and they will like take a migraine, like a flicker of a light will make a migraine patient think, oh, that's my aura, I'm going to have a migraine. And they would have full on panic. And so I would give them, like Ativan or Valium to carry around with them in case they had a sense that this was coming on, and they would pop it. Same thing with my seizure patients. They would take an Ativan if they felt like a seizure coming on. So they lived in panic of their next event. And so when these patients would say to me, I started to feel those PEM symptoms again, I could hear the panic in their voice because they're so terrified of going back to where they were.
They have PTSD for their illness and for doctors. And there is a mind-body connection.
Yeah,
so
absolutely.
Everything you just said makes 100%
Oh, I love that topic. All right, we're going to end this session now.
I just need to say one more thing. One of the amazing things about long COVID, unfortunately, is it has provided us with an opportunity to try to understand why MECFS patients exist. Why did they get there? And this is related to this connective tissue issue. I have not yet met a long COVID patient who did not have a positive past medical history for low-level mast cell activation, not non-disabling POTS, and usually connective tissue stuff. So it's like long COVID has provided us with an accelerated way to begin to understand this, and I hope we take advantage of it. That's why I'm so frustrated with Recover, but they're starting to do some trials, so fingers crossed.
All right,
we'll actually discuss PEM in the next episode.
We'll pick up where we left off, but focus on PEM.
Right.
All right.
So thank you very much.
Thank you for joining on part 1, and we'll see you at part 2. Bye.